My name is Garrett Abel, and I'll be doing a presentation on Ehlers Danlos syndrome and hypermobility. It's a case study of Jesse Cook. So, some characteristics of EDS. So, Ehlers Danlos syndrome, or EDS, is a group of connective tissue disorders that can be inherited and are varied in both how they affect the body and their genetic causes. They're generally characterized by joint hypermobility, or joints that stretch further than normal, skin hyperextensibility, or skin that can be stretched further than normal, and tissue fragility, meaning blood blisters or bruises that appear almost out of nowhere. So, understanding collagen. So, collagen is a protein that strengthens and supports many tissues in the body, including cartilage, bone, skin, tendon, and the white part of the eye. So, up above you see the collagen fibers that break into collagen fibrils. And off of those come alpha chains, and these alpha chains are what are mutated in the EDS itself to cause hypermobility and the certain issues that are along with it. So a few types of EDS that Jessie has. So she has cardiac valvular EDS, which affects the type 1 collagen fibers, or COL1A2. And she also has arthrochalasia EDS, which also affects type 1 collagen and the COL1A2 as well. So diagnosis. These are both diagnosed by a doctor through molecular testing. And they both go through many different pathways in order to accomplish this, but it has to be diagnosed by a professional. However, if you have the inkling that you may be hypermobile, you can test that through the Beighton score or the Beighton criteria. So this is 5 different tests. 1, can you put your hands flat on the floor with your knees straight? Can you bend your elbows or hyperextend your elbow backwards? Same thing, can you hyperextend your knee backwards? Can you bend your thumb back on the front of your forearm? And can you bend your little finger up to 90 degrees to the back of your hand? So all of these are out of a score of 1, which can all add up to a score of 9. So Jessie's symptoms of her EDS. So she has a Beighton score of 7 out of 9. You're classified hypermobile after you hit 5 out of 9. So she is hypermobile. She has a mitral valve prolapse, which goes along with the cardiac valvular type of EDS, along with random accounts of fainting. She has elastic skin properties, also joint subluxations in her hips, shoulders, knees, fingers, and toes, and she also easily bruises. Some implications of EDS on resistance training. So some things that you have in EDS patients are defective proprioception, muscle weakness, decreased endurance, impaired balance, kinesiophobia, pain and fatigue, and subluxations. I'm going to get into all of these in just 1 second. So proprioception. Proprioception is defined as the ability to sense joint position and movement in order to ensure joints are correctly positioned and have suitable muscle tone for activity. So with proprioception, this in an EDS patient means that they don't know where their limbs are in space and time, which can affect a lot of other things that I'm about to go through and mention. Some of which, so the laxity in joint capsule decreases force output. So having the laxity in between the joint decreases your ability to absorb and repurpose force in any kind of jumping or landing or throwing motions. There's also an increased input needed for subpar output. So because of that laxity, there's an increased need for stimulus in order to excite muscle contraction. And because of the decreased ability to produce force or output force, there's a subpar output that comes along with that. And then excessive mobility causes damage to joint receptors. So being hypermobile causes damage to joint receptors, which leads to decreased proprioception in the joints and in the active limbs. Muscle weaknesses. So the most commonly seen muscle weaknesses are the deep core, or TA, glute max and glute med, scapular stabilizers, and postural stabilizers. Endurance. So because of EDS and being hypermobile, individuals are quick to fatigue. So what that means is that their stabilizers fail before their prime movers. And this is quick being to fatigue. On top of that, they have laxity in joints and force transfer, which I just went into. Mitral and atrial valve issues, so going back to the cardiac valvular EDS, Jesse has a mitral valve prolapse issue, and then all of these add up to a decreased ability to recover. So there's an increased need to recover after workouts due to the fact that stabilizers generally fail before prime movers. Balance. So for Jesse, there's more need to concentrate on what needs to be stabilized than other people. Most individuals without EDS can pick up a weight and not have to think about stabilizing the musculature involved. However, if Jessie were to do that, she can go through subluxation or dislocation of her joints just from trying to pick up something and not actively thinking about stabilizing. So there needs to be more of a conscious effort to stabilize than most people. On top of that, there is falls and clumsiness associated with EDS. So because of the decreased proprioceptive input that you have, there's much more ability to fall and also to knock into things when you're not meaning to. So standing up, they can knock into certain counters and whatever else you may be around because they don't or aren't aware that they are there or nearby. Kinesiophobia. So that's people's fear of pain due to movement, which is a factor that can hinder rehabilitation and actually prolongs disability and pain. Kinesiophobia is interesting. Jesse has this as well, where there's an anxiety that's associated with a certain movement. And that anxiety leads to a perceived musculoskeletal pain, and that can mean that she will avoid those painful muscle contractions just because of the fear. And when that happens, she gets a submaximal muscle performance with compensatory patterns around that to avoid the fear of moving something that is going to hurt. And then because of that, there's a poor ability to adapt to those compensations because you can't adapt through compensatory patterns. And then that has further functional consequences if this happens over time. So this is where kyphosis can come in and certain other movement restrictions or bodily dysfunctions can come into play. Pain and fatigue. So with EDS patients, there's an increased fatigue from increased input needed to activate musculature. This goes back to having increased arousal or increased stimulus in order to get a certain movement done, and also having stabilizers fail before prime movers. And this can be related to mitral valve and atrial valve prolapse as well. So a study looked at 273 EDS patients where they questioned them on certain aspects of their EDS. So 237 of those had one or more surgeries pertaining to their EDS. 92% had pain greater than 1 year, and 85% had continuous pain all the time. 89% used regular pain medication. 78% have previous dislocations, and 214 have pain-restricting activities of daily life. And that pain is mainly in the neck, shoulders, hips, and also the legs. Subluxations. So, subluxation is a partial joint dislocation where the joint begins to dislocate but doesn't completely. This is most common in the hips, knees, shoulders, and distal joints such as the toes and the fingers. Now, people with EDS must stabilize their joints before doing any kind of movement under load, or they risk a shoulder subluxation or a hip subluxation, and possibly even fingers and toes as well, depending on the activity that you're doing. For Jessie, her most common subluxation is in her shoulders. Resistance training considerations for people with EDS. So, for people with EDS, you need to prescribe a low or moderate intensity, especially when starting out. You want to start low so that they can become adapt to a lower training stimulus, and then you can increase over time. This will also reduce the risk of any kind of subluxation happening. You also need to make sure you explain the why behind what you're doing to these people because of the kinesiophobia aspect. They may be scared of moving a certain way because it has typically hurt them or it has given them anxiety in the past. So you need to explain why this exercise has been chosen for them and also why it's going to be safe for them as well, so that you can avoid the kinesiophobia and they can make healthy progressions. You also need to make sure that you're training patterns and not parts. So we need to make sure that we're not specifically training elbow or knee extension and flexion, and more work in patterns that incorporate their entire body and can be applied to daily life. We also need to address stability and motor control. So these need to be a strong emphasis in their program because stability being a big part in falling as well as balance, and also motor control being a big part of proprioception. We want to make sure we attack both of these so that activities of daily life are not only easier, but more safe for them. Next up, you need to motivate these individuals. Because of kinesiophobia, they may be very resistant to get into any kind of exercise programs. So you need to make sure you can motivate these people to do what's going to make them a lot better over the long term. You also need to be cautious of end range of motion. You need to start these individuals in partial range of motions to begin with so that they get adapted to those, and then slowly increase the range of motion over time. If you get into a range of motion that these people aren't used to, you can sublux a joint or even dislocate a joint, and we don't want that at all. Also, make sure that you're prescribing full body movements 3 times a week. So this comes specifically with resistance training. You want to make sure you give them a day or 2 in between every time they do a resistance training session because of the increased need to be able to recover. And then stretching may not be such a great idea for these individuals if they're hypermobile. Because of them being so stretchy already, you want to make sure that they can take on some tone that can help them in anything else that they're doing, especially in the weight room or in the gym. Programming. So some things to look at when programming, or the way that I've set it up, is you have a warm-up, full body, that's 5 to 8 exercises. Following that, you have accessory work. So you want to make sure that you can address stabilizing the joints and address that motor control that they need, or proprioception. Going off of that, you want to make your next main lifting movements. So you're looking at things such as the bench, the squat, and the deadlift, which can be varied for the certain individual. And following the main lifting movements, you want to do more accessory work. You want to reinforce that you have stabilized joints and that you have increased motor control. And you want to just make sure that the brain remembers that this is a safe place to be. Going forward, you can do some cardiopulmonary work if needed or if called for, and then test and retest. So if you're doing work with these individuals, grab a Y balance, and then Y balance them before and afterwards to see if they make any improvements in motor control over the course of your session. So you need to make sure that you can assess the problem areas for EDS patients. So some problem areas that Jesse has: pelvic control. So some things that we can do for that are learning how to hip hinge correctly and increasing pelvic floor strength. Also going along with that, joint subluxations. So with Jessie, her shoulders are her main point of subluxation. So we need to do dynamic stabilization of those joints before we even get started so that no subluxation happens. Also, we need to activate what is commonly weak in these individuals. So we're looking at deep core activation. So we're going to look at 90-90 breathing and or deep breathing through the diaphragm in order to activate that deep core musculature. We also need to increase their proprioceptive awareness that we're going to get through dynamic motor control strategies, and then gluteal activation. So this again comes in where the pelvis comes into play. If the pelvis is in the wrong position, you can be doing glute exercises that are actually disturbing the lower back or lower lumbar region instead of actually hitting glute med and glute max. And then finally, posture. So because of how lax joints are, posture can go out of whack sometimes or can be in a non-optimal position. So we're going to use loaded carries in order to fix that issue and to bring tone to the joints involved. Some exercises to be wary of. So Olympic lifts specifically, doing an extremely powerful movement using weight that you have to stabilize over your head or catch overhead is going to be a very strong no when it comes to EDS patients. With these exercises, we can be in danger of complete dislocations for those specific movements. Also, we need to be wary of barbell exercises. Because of how the barbell is more bilateral, it doesn't recruit stability of the certain musculature as much as unilateral exercises would. So we're going to look at more dumbbells and kettlebells for stability work. We're going along. Excessive load on the shoulder joints we also want to be wary of. So that's anything that's overhead, so overhead pressing, overhead push pressing, also any kind of hand walking or handstands are going to be not good for these people also. And then dynamic movements with metal implements we're also going to avoid because of the increased need to have to grab these and then fire them away from you could pull the shoulder joint out, and we don't want that at all. So instead, for any kind of dynamic power movements, we're going to use things that they can easily let go of, such as med balls. So finally, let's go in and train Jessie. This is Jessie doing an abdominal breathing exercise where she's breathing in through her diaphragm with the sandbag being an external stimuli to make sure she's breathing through the right part. So as she breathes into the diaphragm, the bag moves towards the ceiling, and this is the first part of our warm-up exercise.
Good.
Next up, we have a sandbag hip hinge. Here we see her pelvis is in the wrong position.
Yeah.
Her pelvis is anteriorly rotated, so there's
also
an
now
extra
fix
stress
pelvis
on her
forward.
low back. So then we cue her to fix it here, and then
Same thing.
she finally hip hinges in the correct pattern.
Good.
Hips going back to the wall with the pelvis rotated posteriorly
And do
as
one more.
opposed to anteriorly, so you can get that maximum hamstring recruitment.
Burn.
Next up, we have a proprioceptive exercise, so we're having her do the same hip hinging motion. However, now we have her going eyes closed as opposed to eyes open. This is giving her extra stimulus as far as not having her eyes open, so we can propriocept better during our workout phase. Now we have her doing an anteriorly rotated pelvis glute walks. Now, when she comes back, I cue her to fix her pelvis, positioning it in the right position so that she can better hit her med and max glutes. Walking again, backwards and forwards. Next on our warm-up is doing a bear crawl with shoulder taps. This is looking at shoulder stabilization dynamically. And then we have a 6-position carry. So we have her carrying down with the kettlebell overhead, locking in that shoulder stabilization, dropping it down into a front rack kettlebell position, and then also down to a suitcase position. This is working on not only her deep core musculature, but also her ability to stabilize a load in 3 different positions for the shoulder before we get into the regular workout. So this would be done for a couple of reps on each side, just to lock in her stability before we get into doing our next exercises. Then we have, going into our accessory work, we have a kettlebell arm bar. So this is making her not only work on lower body but also working on stabilizing the shoulder dynamically through a range of motion. So kettlebell is acting as force coming down on her scapula, where she has to stabilize dynamically on left and right sides. And then our second accessory work, so we have a sandbag pull apart with a hip bridge motion. So with this motion, we have her going into a hip bridge and pulling apart the bag to activate the scapula and the lats at the same time. And we see that her lower back is not coming up with this much
2,
because this is all
1.
glutes being activated.
Good. Go.
Moving into our actual main primary movement block, we have dumbbell bench press. I'm doing the dumbbell bench press because it's eliciting more effects for her stabilization of her shoulder joint than it would be doing a barbell. She's pushing into the ground for full stability and then going through 8 rep ranges with this exercise before we get into the next one. The next one we have is a single leg RDL. So again, working on hip stability here. So she's pushing her leg back towards the wall while dropping that dumbbell down near her foot. So what this is going to do is not only elicit shoulder stabilization, holding the weight, but also hip and ankle stabilization
2 more.
as well, trying to keep that weight stable going
Last
up
one.
and down.
What?
This side is the side that she's a little bit worse on. She had a slight subluxation of her left shoulder going through the workout beforehand. And now we have her going through her right side, which is her better side that she hasn't subluxed on in the past couple of days. So this side looks very stable considering the other side.
Go.
Then we go into our other accessory work. So here we just have front plank, cued on being pelvic position forward
5, 4,
in the right places
3,
to activate
2.
deep core. And then here we have a dynamic balance exercise working on not only glute flexion, also looking at reciprocal side hip flexor.
Good.
And then in this one, there's much more stress because of the cue to keep her pelvis underneath of her during this exercise. So she has to focus on balancing and contracting and stabilizing
Breathe.
everything all
3,
at the same time.
2, 1. Good.
And finally, our last accessory exercise is going to be a barber's carry, going
Good.
down,
Pelvis
and then
forward.
all the way back. Again,
Good.
To keep the pelvis underneath of her, keeping the shoulders back and her chest upright. Here we're just working on posture and keeping everything nice and under
And
load
good.
through the entire range of motion
All right.
until she reaches the stopping point.